I would like to start this conversation. I'd like this to be a conversation. I wouldn't like to lecture because while it comes instinctively, that's not what I'm interested in. The second disclaimer is I'm not a health professional. I'm a linguist by training. So this presentation is really a layman speaking, as it were. But I'm a layman who is interested in health because I'm a consumer of health services and health products. But I'm also really, really interested and curious about how the health system works in relation to, efficacy of its provision, but also, from the point of view of whose health are we talking about, and how do we know that the object of the health services is happy or well provided for. It's well and good to have the health professionals indicate what we should get, but I think that the feedback from lay people like myself is an important part of getting a better healthcare system. In this talk, I really want to talk about health systems, really, and I want to talk about them from the vantage point of view of who I am, what we would call Ubuntu, that, I'm a human, and what does health mean to you? Is it really health or is it wellness? And also, how can that health, be seen from the perspective of entrepreneurship, where we can innovate and come up with solutions that serve people better. There's a concept of stickiness in business, namely, how can you reduce the stickiness in the system so that things run smoother and services are provided better? But more than that, there is a question of, do we add value as we provide these services? I think that is the most important thing that I would like to focus on today and ask questions, really. I'm not going to be able to provide a lot of answers, but I would like to provoke you by asking a lot of questions. Let's go to the first slide. All right. The aim of this presentation is to invite you to see the health sector challenges we face as an invitation to be innovative, to solve problems and assert our values, what I called, also called Ubuntu, to our humanity, instead of making it a clinical process in which, as patients or as participants, we have no say. I also think that I would like to problematize the notion of health provision, especially the deficits in the continent, by inviting us to realize that, there are more health ecosystems than meets the eye. So when we normally talk about health, we talk about a certain version of ecosystem. We're not talking about all of them. Okay. But my biggest complaint is that we have not done the basic ethnographic research to understand health ecosystems so that we can understand how to leverage them, strengthen them, and maybe increase access for impactful health provision. I say this because when you look at standard health, what I call contemporary biomedical health, access to it is for those who are privileged. For the vast majority of people, access to this health provision is limited. Okay? But there are other health ecosystems that I would like us to look at and ask the question, is it possible to have a comprehensive view? And that comprehensive view may actually open up the possibility of tapping into other health ecosystems that could actually give us more access and maybe even better health. I would like to take a close look at childbirth deliveries at home as a case study, and look at how this phenomenon of children born at home is indicative of something that is happening that we don't account for. Now, I would like, or maybe some of you are online, those of you who are online, just put on the chat, how many children do you think in the continent are born outside a health clinic or a hospital. Percentages, throw any percentage. And Timothy will help me understand what you've put there because I can't say it. But this is an interesting question. What do we think is the number of children that are born outside of a health clinic or a hospital? Okay, I can give you an example. I was not born in a hospital myself. I was born at home. I was child number 7. You can say that was a long time ago, but it is very interesting when you look at the research, how many children are still born at home and not born in a Western or biomedical clinic or any of that sort. So we would like to look at this and say, what is going on in there? Who are the people who are providing the health service in that context? Okay. And do we recognize them? Do we count them when we look at health provision in the continent, or do we not? Lastly, really, I would like to invite you to join in a movement of rigorous ethnographic research of the various health ecosystems so that we can better understand them and hopefully strengthen them in order to increase access to health provision, which to date looks like a distant dream. Just, you can do a short calculation. When you look at the deficits that are indicated in the literature, how many, it's like only 40% of people have access, to a Western trained medical professional. Only 40%. What happens to the 60%? Where do they go? How are they assisted? So it looks like a distant dream to think that well, definitely not in my lifetime, but in a few decades, we'll be able to provide the services as required, because I think the deficits are just too high. So I'd like to invite us to undertake this research of understanding what other health ecosystems are there, how do they operate, who operates in them, and are there opportunities for us to work with them, strengthen them, and make them part of the recorded version of how we provide health services. Next slide, please. These are some of the questions I will be throwing around. What do we know about sub-Saharan Africa health? What do we know? Okay, so we'll look at some of those, evidence or, notes on what we know. When the World Health Organization and the World Bank talk about health in Africa, what are they talking about? Which health ecosystem are they referring to? Which one is included and which one is not included? I would encourage any of you who are interested in this topic to read something called The Burden of Disease, looking at Africa. It's a very, very insightful study. It makes you very angry, but that's what is out there, that Africa is still viewed as the continent with the burden of bringing disease to the world that are not well contained. And I think that the Mpox outbreak recently has just made things even more critical in that regard. And then I would like to look at what are surprising observations regarding Africa's health situation. We want to look at the big picture and the small picture. What do we see when we look at this? Are there any paradoxes or interesting observations that emerge? Okay, and then what is the problem and the call to action? This is what I will also look at. Let's go to the next slide. Now, if you just ask the question, what do you know about health in Africa? What was really, really interesting to me is, I wanted to use an authoritative source rather than a non-authoritative source. And I found this quotation from, the Atlas of Health, Africa's Health Statistics. And it is insightful to see, what it says at the beginning of the report. Because if you read this, then by the time you read the rest of the statistics, you are already not sure what you're reading, okay? So it says that subsections of the Atlas use data that are not recent or up to date, which means that it is urgent and important to invest in data systems if we want to have quality evidence for decision making. This is a collective effort involving all stakeholders, at the national, regional, and global levels. The WHO Regional Office for Africa is committed to working with all partners to support countries to produce quality data. Okay? It's not just quality data, it's the research itself that is, a problem. So, here I'm indicating that there's a problem already with this data that tell us what the health situation is in Africa. I'm not saying that they're not true, but I'm saying that maybe they're outdated, but I also think that the coverage is not quite up to date, up to scratch. So accurate and reliable data in African systems is difficult to find, okay? There are many reports that tell you what is going on, but just this health warning tells you that there is a lot of work that needs to be done. To me, as an entrepreneur, this is an opportunity for us as scholars to get in and fix the problem, okay, by doing really, really rigorous research that helps us better understand what the environment looks like. Next one. Now, I took this data from Deloitte, okay? And Deloitte is a particular interesting slant in terms of how Africa's data is used and how it is interpreted. You can definitely see from this data that the approach here is one of how can we make a little bit of money out of Africa's misery, okay? And I'm not saying that that is wrong, but it is an interesting way of looking at it. When you look at health expenditure in sub-Saharan Africa, okay, you see that it's pitiful, right? So no expenditure on health, we're not supposed to be entitled to better results, okay? And then when you look at, out-of-pocket costs, how much you pay for health services, it's very high, but the incomes in Africa are very low. So as a proportion of your income, health service provision is very expensive. And here we're talking only about the standard biomedical health provision. Okay, it doesn't talking about going to my shaman or my other multiman that might assist me. It talks about the cost of that health provision. And then when you look at the density of healthcare professionals, okay, compared to the population, absolutely low, right? In fact, it is the lowest compared to other regions of the world. So I know that you guys know these statistics, but what we will be looking at here is the bad news. Then we'll start asking ourselves, wait a minute, are these bad news really bad news comprehensively, or they're bad news only in a sectional way of looking at one ecosystem? Health expenditure as a proportion of GDP, again, very low. Most of health provision in Africa is really just run by NGOs, and then governments sort of don't provide enough coverage for that. I do know that the governments don't have a lot of money, so the issue is not a blame game. I do understand what the situation is, but nonetheless, the less we spend on our own health, the less we should expect better results. Okay. And then when you look at the domestic private health expenditure, again, it's very high. And then you look at, and I want you to note this last one, the nurses and midwives to 1,000 people. Okay, really, really interesting that it's so low. Okay, and I want to contrast the slide, the one on the far bottom right corner, with the number of children born at home, and ask who then is delivering all of these children if the ratio is so low, in terms of midwives and nurses. Next slide. Now, here I'm just showing the slide about infant mortality rate, okay? And whereas you can read this slide as doom and gloom, I'm reading it very differently, because I'm asking myself, wait a minute, the best country here is are the ones in green, right? 24 or 25, 10 to 25%, right? And then you look at the worst countries, 75 to 100 per thousand, okay? Those of you who did maths, okay? we will realize that 100 out of 1,000, I think, is it 10%? Someone correct me, I didn't go to med school. Okay, the number is very low, right? So what you are saying is that the infant mortality rate, okay, even though it's not good as a world average, it doesn't look to me to be, a really bad figure, because I'm asking if the midwives and doctors to ratio of midwives and doctors to the population is so low, how come we have such a high survival rate? You would expect a calamity here. And I stand to be corrected by those who know better, but that's how I'm reading the slide. Next. Now, there's this interesting paradox of Africa here, right? That sub-Saharan Africa has a shortage of healthcare workers, despite the widespread unemployment in the sector, right? So when you look at demand is high. Provision, right? It's low, but even though it's low, there are some health workers that are not employed. By employment, we mean that they are not formally employed by someone who pays them a salary. We're not talking about entrepreneurship, right? But there is no doubt that even though we're producing health workers and some are unemployed, our provision of health workers is still under what we should be providing, which is the gap that you see of 5.6, of minus 5.6, and then going up to 2030, going up to 6.1. So we need to train more people in this health sector, even though there are some people who remain unemployed after being trained. I'll park this issue about what is the problem there. Maybe the problem is not that they have been trained, they're unemployed. Maybe the problem is that we're looking at employment as the only thing that can make you use your skill. Next. This is one of the paradoxes of all for me, is that despite all the bad news, okay, the population of Africa is still growing, okay? And I just want you to spare a thought for this one thing. If we had all the indicators, right, working right, would the population of Africa be growing even faster, higher? Maybe. That's the only conclusion I can draw. So the population is growing. We know that we don't have good health metrics, but the population is still growing. I would like to understand what is keeping the population growing. Is it in spite of all of this bad news, or is there something else going on? And I think that, as you may realize, my inclination is that there's something else going on here, which we're not fully explicating and understanding in terms of the health ecosystem. Next. Okay. Now, I found this quotation, which was really, really interesting to me, that there's research out there that recognizes that there's traditional medicine, that it remains widespread in developing countries, okay? It is used in tandem with the biomedical approach. Now, the question then is the following: what is the extent of the existence of these traditional medicine practices on the continent, and who is tapping into them, and to what extent are they tapping into them, and what is their efficacy? Okay, and I don't know the answers to those questions, right? But I think that is the research question. What is the ethnography of these traditional medicines or practices and other ecosystems, and how much penetration do they have? Who uses them? When do they use them? How do you make the decision between using traditional medicine today and then using a biomedical doctor on the other side? I don't know what the decision-making is like under those circumstances. And I think that for us as scholars and academics, it would be interesting to explore that dark corner, to understand the decision matrix. When do I go to see a doctor in a hospital? When do I go to another provider, and for what services? Okay, and what goes through my mind as I make those decisions? So we have here proof positive that there are other ecosystems that are living side by side with the biomedical one, but I'm not sure that I've seen really, really good research that tells us how they interact, and how they work together or complement each other in the space. Next. Let's go to the next one. Okay, what is missing here? I say that we do not have a comprehensive, ethnographically documented and rooted understanding of the health systems typologies that support health on the continent. We operate from the basic premise that the relevant and varied health typology that is required and credible for assessing and evaluating Africa's health drivers and determinants is the biomedical Western health. We take no account of any other health systems typologies that support lives, which are used by the population, where access to the standard model has a poor penetration of the population and is therefore inaccessible, both in sheer availability and just cost. So here's a good example. I will deviate from this and just tell you a little story. I live out, I was born outside, the nearest town is like an hour away by car. Okay? When something happens to you when you live in that area, you really have to decide if you want to get into a car and go there. Car may be someone giving you a ride, or alternatively, you go and wait for a bus. Okay, so it's not easy to go to a clinic. It's very far. So there is the distance. Even when you get there, you might find that it is closed because they operate at other times and they close at other times. They'll tell you are outpatient, you are not emergency. Even if you do get there, the doctor is not around. The nurse sees you, okay? If the nurse, they might prescribe something for you. They're not supposed to, but they will because the doctor is not around. Even if you do get the health practitioner, okay? The health practitioner may prescribe something that you can't afford. They may prescribe a procedure that you cannot afford. So there is a problem here in that it's not just distance. It's not just getting to someone. Even when you do get someone, you can afford their price. Even if you afford their price, you can afford the prescription. Those are the challenges that is missing. So what we want to understand then is what happens under those circumstances. Do people then go to the other health ecosystems? What is their cost? What is their efficacy? And what is their availability? Those are the things that I think that what is missing from the literature and the health metrics in Africa, that will give us a much more rounded picture to understand how the population behaves and what constitutes decision-making of which ecosystems to go to. Next. Let's go to this, my favorite topic, which is childbirth at home, right? Now, there is a lot of research on unregistered children you will find in the literature, okay? Nobody ever tells you, how is it possible for a child who is born in a hospital or a health center where documentation is done instantly? How come we have so many children who do not have registration or documents to indicate when they were born, by whom, and at what time? Okay. Now, this is a big issue. I'm told that East Africa has the highest number of unregistered children, okay? And I am using, and I may be wrong here, I'm using the non-registration of children as a proxy for where children are born, right? But if a child, I had the same problem, I was born at home, right? And my mother never bothered getting the piece of paper. When I had to go to school, the question was, when were you born? Okay, now you have to go and ask at home when you were born, right? And then the struggle to get you a birth certificate begins, okay? So this issue tells us that there are a lot of children that are born at home. In some instances, close to 50%. But what is very interesting to me is who is providing the health care to those women who give birth to children at home? When does the healthcare provision start? By whom? What competence does the person who provides the healthcare have? What is the efficacy? How does the pairing happen between, this undocumented midwife and the expectant mother? These are the questions that, really, really, I think when you're curious, you want to understand what goes on in there. What is the nature of this relationship? Why do women choose to have children at home vis-a-vis going to a hospital? Are there enough beds in hospital to start with for everyone to have a child in a clinic or in a hospital? Okay. There are many issues here that remain unknown, and I think that if we could use this as a starting point of doing really rigorous research, of understanding ethnographically what the terrain looks like, we can then begin to understand the cause-effect relations, okay? But we can also understand who is there, how we can empower them, how we can leverage them in order to provide better health, but also how to record them as providers of health in the whole ecosystem, okay? One of the questions that I raised at the beginning was this: why is the mortality rate so low if trained care workers are so few? And the point I'm really making is that if you look at trained health care workers providing services to the population, there's just too few of them, right? You would expect, if 50% of the kids are born outside of a hospital, a chance survival rate. But I don't think that we have a chance survival rate here. The probability doesn't look like chance. It looks to me like there is efficacy of the health workers who are not documented, who are providing these childbirth support systems, but are not recognized, are not part of our statistics. Next. Always the question is, why undertake research, okay? Well, I think that we can validate the existence of a much broader health ecosystem, okay? And that would not make us worse off. We would understand better what is happening. There is a possibility of leveraging and strengthening the ecosystems, okay, as a whole, so that all of them play a part in providing health for the continent. And then there is a potential for better access to health. This, in my opportunity, is an opportunity for entrepreneurship in health. When you start thinking about the provision of health in a much broader sense than providing a pill or providing a doctor that takes 7 years to train, I think that that's where we can look at a broader pool of people who are providing health, community health, and all of those people, but who are not visible to the system at this point. Would recognize the invisible health workers that are there, posthumously. I would like my grandmother to get a certificate for delivering me because she was a health worker, but she was not recognized. And then we can affirm other health provision channels officially, okay? And in my view, this would be a good step of affirming those people who have always been there providing health, unrecognized, and once they become part of the system, then they can also have status, which would affirm their humanity, Ubuntu of those people as well. Next. That is the end. Thank you. So I'd like to sum up as follows. Of course, I'm not a health expert. There will be many mistakes in this presentation. But I think we are getting a sense of what a person like me who is lay, who is interested in the many, many questions in health would ask. And if in all of this I'm completely wrong, then I think that the people who are in health, who are professionals, have a job to do, to educate people like myself so that we understand better what is going on. So I don't lose here. If I'm sharing my ignorance, please help me understand. But if there's something that is in there that we can learn, maybe let's do some research from an ethnographic point of view of understanding the broader health systems, ecologies that are among us. And there will be many permutations of them. It won't be the same one in each region, in each culture. You will find differences, but it is the notation of those cultural variances that actually makes these systems even stronger. Thank you very much.